Hello, and welcome to the Smith & Nephew Wound Club online module on biofilm, which forms part of a series of modules you can access to develop your knowledge and understanding around infection and management of this condition. Today, we will be discussing biofilms. By the end of this module, you will be able to understand how a biofilm forms and matures, have a more in-depth understanding of the challenges that a biofilm creates for us as clinicians. So, let's talk about biofilms. Traditionally, assessment and management of wound infection or bacterial burden was focused on planktonic microbes, which are free-floating, free-living bacteria. Planktonic bacteria can be eliminated by the host's immune system or specific antimicrobials. Biofilm bacteria are adherent bacteria enclosed in a protective polysaccharide matrix. Biofilms are protected from phagocytosis and macrophages and neutrophils, and they are highly tolerant of antibiotic and antimicrobial agents. Biofilm awareness has increased over the past decade and gained attention in wound management. Aside from etiology and comorbidities, biofilms are probably the most important single cause of delayed healing. Examples of biofilm outside of wound care include plaque in our teeth, routine visits to the dental hygienist are necessary to remove this biofilm because they are not removed by brushing alone. So how can we recognize biofilm, and how should we manage wounds in order to remove this biofilm? There aren't any diagnostic tests to identify biofilms, and early signs of biofilms cannot be seen with the naked eye. While slough may be a downstream result of biofilm, slough, debris and exudate should not be mistaken for a biofilm. The consensus guidelines for identification and treatment of biofilm in chronic wounds suggests clinical findings which may infer the presence of a biofilm. Specifically for biofilm reduction, the guidelines recommend repeated debridement to physically remove the biofilm. However, debridement alone is not enough. Biofilms may begin to reform within 24 hours. Therefore, the use of an appropriate topical antimicrobial agent may help to prevent or stall the regrowth of a biofilm. Formation of the biofilm. So when bacteria in and around chronic wounds are slowly allowed to multiply, they will ultimately reach an essential critical mass. Microbes loosely attached to a surface, they then multiply, allowing them to irreversibly attach to the surface and form microcolonies. Bacteria are embedded in a matrix containing both microbial and host components called an extracellular polymeric substance, an EPS. This is typically made up of polysaccharides, proteins, lipids, and extracellular DNA. Microbes, however, continue to multiply within this protected community. This EPS substance creates a barrier that limits the influence of the host's immune system, antibiotics and antimicrobials. It allows them to be adaptive to changes in their environment. Microbes can disperse from the edges of the biofilm individually or in clumps to colonize new surfaces and cause recurrent infections. The protective capsule helps the colony expand by providing protection from the body's natural defenses, such as being engulfed by macrophages. In response, the macrophages release proteases designed to break down protein. So this ongoing presence of a biofilm triggers a prolonged inflammatory response in the host body. The continued release of proteases by the macrophages degrades growth factors and the provisional tissue matrix essential for healing. There's a very strong link between biofilms and chronic persistent infections in the body. Biofilms are medically important and linked to many hospital-acquired infections, accounting for around 78% of persistent microbial infections. They are a reservoir for recurrent infection, and with minimal treatment options, there's an increased tolerance to antimicrobials, such as antibiotics and antiseptics, which will compromise your host's immune response. Now, standard wound swabbing and culture techniques detect free-floating microbes. They do not detect the microbes within the biofilm itself. This means that swabbing the wound, that the results will often underestimate the microbial load when a biofilm is present on the host. So the topical antimicrobial dressing's performance is also variable when challenged with a biofilm. The negatively charged biofilm matrix slows the penetration of positively charged antimicrobial agents such as Ag or silver. Positively charged antimicrobial agents such as ionic silver, Ag+, are impeded by bonding to the negative charge of the biofilm matrix, reducing the amount of silver available to kill these bacteria. Mature biofilms are difficult to eradicate with antibiotics. Antibiotics only kill metabolically active bacteria, often only found in the outer layers of a biofilm. The inner layer is metabolically inactive, and the bacteria deep within the biofilm will be unaffected by the antibiotics. Now, to check your knowledge and understanding, try and answer the following quiz questions. Question 1. What are planktonic bacteria? They are free-floating, free-living bacteria. Question 2. Can you physically see a biofilm? No. They are invisible to the naked eye, and at present no diagnostic tests are available to see the biofilm. Question 3. How can you prevent or stall a biofilm? Repeated physical debridement along with appropriate topical antimicrobial agents will prevent or stall a biofilm. Well done. You've now completed this bite-sized module. Take this time to reflect on how you will take some of what you have learnt today and apply it into your daily practice. Please click on the link in the description below to go to the full 15-minute version of this presentation. Once this is completed, you will have the opportunity to download CPD revalidation forms. Again, thank you for your time today. Please remember to look at the other sections to access additional modules to help you along your learning journey. Thank you very much.